Hello, and welcome to another episode of No Notes, where the conversation is always a perfect 10 out of 10. This podcast is powered by Elios, the most used and most loved AI platform in behavioral healthcare, equipping more than 210 organizations and tens of thousands of providers with powerful automation tools that streamline documentation, simplify compliance, and surface deep care insights that drive better client outcomes. I'm your host, Dr. Denny Morrison, and for today's episode, we are excited to be joined by Dominic Miller, founder and principal of Sotoro LLC. We'll chat about the recently passed One Big Beautiful Bill Act, OBBBA, and all the ways the new law might impact behavioral health care in the United States, touching on everything from funding cuts to new grant opportunities. And we'll lay out some practical strategies for protecting care access, sustaining operations, and using technology to help weather the storm. So welcome, Dom, and thank you so much for being here today.
Thank you, Denny. I'm very excited to be with you and to talk about OBBA, as you mentioned, the One Big Beautiful Bill Act. There's a lot to unpack.
Well, tell us a little bit about your background. How did you get into this, and what's your background?
Yeah, absolutely. So, as you mentioned, I'm now the founder and principal of my own boutique consulting firm, Sotoro LLC. Spun that up about 2 months ago now. It's been an exciting 2 months, so we're still kind of new on the block. But before that, I was previously the chief operating officer of one of the largest behavioral health provider organizations in Arizona, Southwest Behavioral and Health Services. And so during my time as an executive in the behavioral healthcare space, I took on a lot of new experiences. We had some great outcomes and growth at Southwest Behavioral and Health Services, and I had the privilege of overseeing almost every line of behavioral healthcare, primarily Medicaid funded by behavioral healthcare.
And that's exactly the kind of focus that we want to have today on our conversation today. So why don't help for the audience kind of do some level setting here. Why don't you talk a little bit about the Big Beautiful Bill Act and what are its implications for behavioral health providers?
Absolutely. So on July 4th, the nation's birthday, and also subsequently the month Medicaid turned 60 years old, which was last month in July. The president signed into law the Budget Reconciliation Bill, or commonly referred to as the One Big Beautiful Bill Act, or we'll say it as OBBA, but One Big Beautiful Bill Act. And really, it's a sweeping budget law that contains a lot of stuff. It contains tax cuts, border security, and spending policy, and it really aimed to be the core of the president's second term agenda. The interesting thing is that although it wasn't aimed at healthcare specifically, there's a ton of implications for healthcare, and in particular Medicaid, which we'll spend a lot of time on today. And then, as an after effect, that means behavioral health is kind of right in the middle of it. And so for the audience and those that are interested in some of the implications as it relates to just high level impact and then behavioral health specifically. Some numbers I'll throw at you, Denny. So the bill is projected by the Congressional Budget Office to increase the federal deficit by $4.1 trillion, cut Medicaid specifically by almost a trillion. It came out to be $911 billion with a B. And then result in the loss or potential loss of healthcare coverage for approximately 10 million Americans. And that's actually down from their original estimate of about 11 million, 11.8 million. But either way you slice it, it's going to have some impact that we're all going to feel in the Medicaid space, no matter what.
Yeah, I do think that all the executives that I know are already um, tracking this and are obviously very concerned about it. Uh, do you think there are any opportunities or chances that parts of the bill will be challenged legally?
I do. In fact, we recently saw some senators introduce technical legislation that would reverse some of the, cuts to Medicaid, for example, that are in the current version of the bill the Senate passed, that's now signed into law. And so, there's a couple of unique things that happened as it related to OBA. So, it's not that we haven't seen this before, but Congress did not use what's called a conference, congressional conference, to help reconcile differences between the House version and the Senate version. Rather, the Senate jammed all of the things that they kind of wanted in that bill, which got signed into law. And so when a congressional conference isn't used, or a conference committee isn't used, sometimes technical errors will be made and things will get missed, resulting in the need for legislation down the line that will need to be introduced to fix those corrections. And so, to answer your question in short, yeah, I think that there are going to be a maybe a wave, maybe a ripple of new legislation that comes out to kind of fix some of the things that weren't caught the first time, or caused, or that will or might cause impact to the space in the future.
So changes could be substantive, not just technical changes because they didn't do a conference committee, but they're using the opportunity of a technical change to maybe rethink some of the policy related issues like Medicaid. Is that part of the
Absolutely.
strategy? Okay, very
Yeah, I would say both and substantive and technical changes in new legislation are likely to be seen.
so. Walk me through kind of like the downstream effects of this. So you've got, we know that Medicaid, as you said, it's going to take a huge hit. I mean, we're thinking about this as a tsunami heading our way. Um, we know that behavioral health organizations like the ones you and I both worked in are heavily funded by Medicaid. Walk us through what the downstream implications of this, if there are no changes.
Yeah, I mean, for what it's worth, as it stands today, the Medicaid implications alone include cuts to federal Medicaid spending around roughly 15% over the next 10 years. And so, I'll mention this here and maybe we can come back to it later, Denny, but there are some wins that we saw, or I'm classifying them as wins. And one of those is the phase in, phase out approach to different stages of this. And so it's not all happening at once. In fact, some lawmakers on the Hill wanted immediate cuts to happen. But the result of the legislation was that it'll happen over the next 10 years. And so 15% might sound small, but when you're talking about Medicaid, one of the largest budget items of the federal government, you're looking at about 911 billion. And so that's primarily made up of three ways or three mechanisms, so to speak. First is the tightening of eligibility. So making that harder to enroll or re-enroll, uh, that that will happen to the tune of 250 billion estimated. The addition of work requirements for enrollees on Medicaid. So we saw this happen in Arkansas a few years back, and we know that there's some challenges with that. That the state actually had to reverse that protocol, but that's estimated to make up about $320 billion. And then the capping of several state funding tools or mechanisms are going to result in an estimation of $340 billion. And so you see there that there's a lot of this spending cut in order to fund some of the other policies that the legislation has in the numerous provisions currently in the bill.
So, what implications will this have for community behavioral health providers?
Well, I mean, if you run a clinic, you contract with an MCO, you have a crisis line. I think OBBBA touches the payer mix. While the bill doesn't aim, or like the legislation doesn't aim directly at behavioral health, what we do know is if Medicaid is reduced, so to speak, the pie shrinks, then less funding is going to go around for us to tap into. And so, while other payers and private pay and self pay and grants might still be in existence, there's a real potential for some of the Medicaid funding that we rely on in behavioral health to really be shrunk, and that's primarily through the hospital systems, or larger healthcare systems that rely so heavily on the funding. In addition, I'd mentioned that the CBO's estimate is 10 million people losing healthcare, and that's 10 million enrollees that were funded by Medicaid, and so therefore you have a direct impact to payers, and then subsequently provider organizations from potentially losing membership over the legislation.
I know in back when I ran a mental health center, our revenue mix was probably 70% Medicaid. Was that true in your organization in Arizona?
It was even higher. I mean, the agency that I worked at was, around 87 to 90% kind of, given the fiscal year, but other organizations are 100% in Arizona. And so absolutely.
So, as you know, you're chief operating officer. Uh, in your budget, probably if you have to make cuts because of these changes, there's no way to do substantive cuts without hitting people because that
That's right.
your human
That
resources is your number one line item. You can't save enough on paper clips and copiers to make any dent. So one of the downstream effects looks like, unless things change, that a lot of these providers will likely have to lay off clinicians. Do you think that's true?
I do think that's true, Denny, and I would also just mention a lot of organizations are coming to me, for consulting on this because they want to know, do we make austerity cuts? Do we, try to trim, like you had mentioned, on office supplies? Quite literally, one was asking, what programs to shut down if I felt there were any that were at risk. And I don't think that austerity cuts are going to, help providers weather the storm fully, so to speak. Like I think that there's many different strategies and things that need to be planned for strategically that include perhaps some cuts, but ultimately it's about pivoting and looking towards other ways to braid your funding or do things that are innovative like adopting tech and making efficiencies kind of priority rather than just cutting all of the positions that are mainly funded by Medicaid. I mean, the system will have some knock-on effects occur, such as consolidation. I think that there's states such as Arizona where there's a lot of different players in the behavioral health field. I mean, there's hundreds of providers, and so I predict a lot of M&As, mergers and acquisitions occurring. I think that people are already starting to kind of go down that path. And then others might just have the acquisition side and be absorbed into larger organizations that have the bandwidth to support them. And so, yeah, I completely agree. I think that there are, looming cuts, so to speak, but I don't want to spread panic. I want to spread planfulness, right? And so that'll be a theme of kind of the conversation as well.
Yep. And I agree with that. I think, I mean, as you know, I think you and I talked about this when we planned for this call, that one of the hallmarks of this administration is unpredictability, which which is worse than having bad news as a manager. I mean, I'd rather you're going to tell me I got to cut. Okay, I can work around that. But if I don't know where things are going to go, that's unpredictability is like the bane of management, in my opinion.
It's the hardest thing. I mean, you want the answer. I think is human nature to fill the gap with the worst outcome possible, and so you have executives that quite literally are having a lot of anxiety over this, and not for bad reason. I think that there is a lot to consider, and so we'll talk a little bit more about what executives can do later on. But I think that you're absolutely correct. It's the bane of the manager's existence right now.
Well, you know what? The other downstream effect that I'm also aware of uh, is that not paying for care does not make the problem go away. The problems will still exist. So you've got 10 million people who are no longer on Medicaid who do not have resources to mental health care. And if history is any predictor, those people will then not seek care until they escalate to a point where their pathology or their problems have gotten exacerbated, and they will hit emergency departments and other high cost intervention sites. And the EDs cannot turn them away by law. They have to see them. So it seems like there's there's almost like an unfunded mandate that's coming along for healthcare institutions, EDs particularly, who are going to be who are going to see some major increases in their indigent care showing up in the ED. I mean, does that flow for you as well? I mean, do you see that?
That's absolutely right. I mean, you said the problem persists, right? It's not going away. Someone's got to pay the bills as well. And in this country, we have a system that, there are some large healthcare insurers that own hospital systems that also fund behavioral health organizations through their MCO model. And so while we're not talking about the, healthcare exchange or the ACA today, as much as we are Medicaid, I mean, think about it. I mean, hospitals are getting their funding cut and insurers still have to pay, then I would predict, your private plans or your ACA plans premiums are going to go up. There's other ways that insurers will have to fund, like you had said, these unfunded mandates or these mechanisms that they can't turn people away, like emergency rooms. I think we can see that increase um, over the next 10 years, absolutely. But I think it's going to start happening sooner than later. I also want to mention, behavioral health is ultra exposed to Medicaid, right? And so not only behavioral health, but including substance use disorders, specifically those, we call it medication assisted treatment, or medications for opioid use disorder. If you miss a methadone dose or a buprenorphine um, appointment, that could have devastating consequences. And so the risks just kind of skyrocket. And it doesn't just have to do with substances, right? But if you miss a therapy appointment, or if you're a high risk person and you have a lot of different complex needs and you miss your case management appointment, that could lead to, like I had mentioned, adverse outcomes and potentially devastating for families.
Well, and I know in your organization, this is true. I know it was in mine. We have case managers who do a really good job of kind of managing the the clients who under their care, and I mean in terms of things like making sure they are making their Medicaid eligibility appointments and they're keeping track of this stuff. The the eligibility requirements and the work requirements that you mentioned are it seems like that's gonna place another whole level of complexity on the backs of particularly case managers, mental health organizations certainly, but it'll end up in the case manager's back. How do you think that's gonna play out?
Yeah, that's a really good question. And so, I come from an organization where there was one dedicated kind of Medicaid enrollee specialist. Um, that's aside from the case management that are kind of helping with treatment, right? My recommendation would be to really think through if more resources should be allocated to folks or employees that are specializing in helping redeterminations and just Medicaid applications in general. I know that kind of feels not so great to some executives because those aren't billable services, so to speak. But if it maintains your base and kind of stabilizes your enrollees from dropping off Medicaid, I think that might be worth exploring and could be what is needed for organizations to continue.
Yeah, one of those the eligibility requirements are kind of one whole ballywick, but the work requirements, the some of the data I've looked at said that the the people who can work who are on Medicaid, most of them are working. How big is the opportunity to get people who currently are not working on Medicaid to get them working? Is there a lot? Is that a big percentage?
It's not. I mean, like you mentioned, it's true that the majority of people that are on Medicaid are either working or applying to jobs or seeking employment. I think that that's true across the board. As you kind of zero in on behavioral health, what's I think a win for behavioral health with this legislation is that there are broad exemptions from the work requirement rules. And so folks that are designated using their terminology medically frail, which isn't my favorite, but that's what they use. And that would include substance use disorder and serious mental illness and behavioral health conditions. And so looking at what the actual eligibility requirements are, plus the work requirements, will be really important to understand if your organization will need to kind of focus on workforce development programs, or strategies to help folks get on, job or get jobs or become employed. Skills training was a huge code that we build at Southwest. It's, essentially just that. It's helping folks, um, develop the skill set needed to enter the workforce. And then in addition to that, there's vocational codes and rehabilitative codes that focus centrally on employment. And so the opportunities are there if you find yourself with a mix of Medicaid enrollees at your organization that do in fact need to try to be deemed working or trying to seek employment. I believe there's some timeframes around, how long they need to be seeking employment before they become eligible. I think it's 1 month before application. And so, that in addition to thinking about all that paperwork, I mean, that's a lot of paper. If you've never seen a Medicaid application, I kid you not, they are thick and they've grown over the years. And so I think that that really ties into the conversation around work requirements because what we're talking about are more administrative burdens.
Well, that's that the difficulty of that application process is one of the reasons why your organization, as did mine, we had people who were dedicated to making sure all the I's were dotted and T's were crossed for that. When we look at kind of who's going to be disproportionately affected by this provider wise, do you see any trends there? Like there's, I mean, community behavioral health is not a homogeneous thing. It's there's urban, there's rural, there's, Matt, there's, all this other stuff out there. Who's at most risk, do you think?
Yeah, I really think that rural providers, behavioral health, but inclusive of rural hospitals and, primary care, all of the, you know, organizations that make up that rural system are really going to start feeling the impact and I think are at more risk for potential closures of clinics, potential closures of hospitals. I mean, rural hospitals already operate on such low volume, but they have high fixed costs, right? So you're talking about cutting some of the the dish payments, the cuts to those or the disproportionate shared hospitals will resume after a moratorium of 14 years, and that's in fiscal year 26 in a couple of months. And so I think that that's the one that sticks out to me first. And then kind of as we were talking about earlier, some of the more high needs or complex populations that really rely on home health services, for example, or those that have some intersectionality with diagnoses and perhaps they have intellectual developmental disabilities and a behavioral health diagnosis and in some cases a substance use diagnosis on top of it. Those are the populations that I think that in addition to the rural health systems, and organizations that serve those complex populations are really going to have to grapple with some, um, you know, fiscal coverage cliffs, if you will, or kind of other negative impacts of the legislation.
Yeah, I agree that diagnostic group which is pretty much everybody that comes to community behavioral health. You rarely see somebody who comes in with a straight up anxiety disorder by itself. Um,
That's right.
so you mentioned this though? I'm just curious. Do you think there's a couple of other domains that are not specifically community behavioral health, but like for example, you mentioned IDD providers, and just presume for a moment that they are straight up just IDD. We know there's secondary diagnoses. They and family and social services, foster care, those kind of things. Do you think those are going to be impacted with this?
I think generally, yes. What comes to mind is looking at systems that aren't primarily funded by Medicaid. Maybe there's other funding mechanisms, federal funding mechanisms that are in place. The corrections system often comes to mind, or law enforcement. They're earmarked, appropriated, and allocated funding to provide services in some cases, and they actually subcontract or contract with provider organizations to do that work. And so IDD uh, is an interesting one because I think that while the legislation doesn't aim similar to how it didn't aim at behavioral health, I think that the knock-on effects are going to be very significant for populations because that in particular the IDD population because of the heavy reliance on Medicaid funded providers or elements of their treatment plan or care team that are in fact backed by Medicaid dollars.
I think on one hand, the IDD providers have got one thing going for them in that a lot of their funding comes from school systems. But I think school systems are under pressure too. And I just read something yesterday, I think, that that independent of the Big Beautiful Bill Act, that their school systems are starting to see cuts for special needs services for kids who have IDD, whether they be serviced locally, in their own classrooms, or they have to be referred out to specialty care units. It's again back to it's kind of a crapshoot here. I mean, we do the stuff we know about behavioral health care, though, and Medicaid ties makes that, if it doesn't change, that's pretty predictable. But And I agree with you about the rural providers and those complex cases. I mean, that's, those are like the bread and butter for a lot of behavioral health organizations, community behavioral health organizations. And that's what they do really well is the ability to manage all that stuff and prevent hospitalizations. And I'm just worried that this infrastructure is going to get tanked if we're not careful. So, well, let's talk a little bit about the bright spots here. Yeah, we've been talking doom and gloom here, and this the financial tsunami that we're all looking at. What's the upside here? What kind of things do we have that we could look forward to?
With this, I mean, if you've been following the saga that was this bill getting signed into law, over the course of the year, the last couple months especially, you do know that the bill doesn't look the same as it did day one when it was introduced, initially, and so in both chambers. And I think one of the things I like to call out in terms of bright spots is that I think I'd mentioned this, but some of the lawmakers on the Hill wanted to go further, right? They wanted to cut further and they wanted to cut more immediately. And I take it as a huge win. It might seem small to some, but they didn't. We were able to, or those advocating, for healthcare in this country were able to have the phase in, phase out stages of the bill. And I think that's really key. And I say that because it allows executives and leaders in the behavioral healthcare space to start strategizing, to plan, to roadmap out what they're going to do each month of or each quarter of the fiscal year at whatever cadence. If we didn't have that, I think it would be more of a crisis, and the tsunami would kind of be at our doorstep more so than we're going to be able to kind of plan to strengthen and fortify some of our systems. And so that's number one.
It's more like a
Other
series of bad waves coming, not one big tsunami.
Right, and I mean, there's an argument to be made about that too. I mean, that's probably more difficult in some cases. You might lose your insurance. Just kidding, Florida. But I think that there's really the bright spots you have to kind of look for with a fine tooth comb. But the zero copay, for behavioral health and substance use care is important. The Medicaid is, historically not had copays for services for treatment, and so having that carve out for our population is really important, and that goes for FQHCs, CCBHCs, and rural clinics, and so that's really if people don't know that, I would absolutely provide that information and education to providers in our space. The other bright spots are the broad exemptions for medically frail, so to speak, people and SUD treatment. Um, that would I would consider be really, really difficult, if not a complete stop to care in some cases, if we had to apply those work requirements. And then a small one that I don't think is very small, but it isn't getting a lot of airtime, is that there was in the Senate version of the bill that was signed into law the removal of a proposed ban on gender affirming care. And so, those kinds of things I think really need to be, more publicized because it's easy to get doom and gloom, right? I mean, you could probably spend the entire time talking about that, but without looking at some of the upside, if you want to call it that, it does, in my opinion, stifle innovation. And so that's really the last thing I'll say is that it provides, space, and action for innovation and for creativity and for providers to, get with their executive teams and strategize about what they're going to do differently and maybe what they're uncomfortable with because of whatever reason and embark on something new that will sustain and stabilize their organization and the system at large.
But you had some really good strategic suggestions, and since we've been talking about the role of leadership and what they're really going to have to do and rethink a lot of things. So, but I know another one of your passions is the technology side, and so where does technology play in this? I mean, we do know Elios does a really good job of helping clinicians document faster and easier and all that kind of stuff. Uh, is, do you see that as a potential help to all this?
100%. 100% I do. I think, with AI ambient note drafting, it saves you about what, on average, 7 to 10 minutes a note. Um, and that adds up over time. I mean, if we're looking at helping people maybe re-enroll or submit paperwork or do some more administrative burden and tasks that they didn't have before, case managers are going to need to be able to save time elsewhere. And while I said earlier, austerity measures and efficiencies aren't going to save the ship from sinking, but they will provide the relief that the actual workers need to you know move forward and not become morale bankrupt. And that's what I really want, provider organizations and executives to focus on is technology and how, if they haven't yet, how can they open the door to AI and how can they open the door to tools like Elios and other, healthcare adjacent tech companies that are really out to support the missions that we're already very passionate about. I particularly am passionate about both. I love, the onset of new technologies and how that can assist clinicians like myself as a therapist, and I should say as a case manager in particular, because I started as a case manager in the field. um, I hated note writing. It actually made me motivated and drove me to get into leadership because I was like, "There's no way I can do this for the next 20 years of my career." And so I embarked, on my journey of leadership to stop writing notes. I kid you not, and I am proud to say that that's one of the reasons why. But if I had to start all over again, it would be a different story because there are tools out there like Elios that will help everyone from the front end to the back end and administrative staff in increasing their efficiencies. And we can talk about the clinician side all you want, but I think there's a lot of value and ROI actually in the administrative functions of an organization, using technology to make things faster, make things automated, using predictive analysis and churn tracking and data points that we didn't have before. Those things are going to have to be a part of the conversation.
Yeah, and in the spirit of full disclosure, when I was a clinician, I was the worst at writing notes. I I'm that I hadn't thought about it. I don't think that really, motivated me so much for management, but I was, happy to not have to do do the documentation anymore, I have to tell you that. So I think that's an experience that we've all had. I don't know of any clinician that says, "I really like doing my notes." Not one. I don't know of any. So I do
That's right.
think, yeah, these technologies really can, can be beneficial, and and I would argue they might become crucial to successfully managing the future here, particularly on the case management side. Because at least on Elios's app, you can do customizations to remind them about what you're supposed to be asking about, and if in the face of change, getting kind of things to keep them on track, and managing all these things we've been talking about, these changes, and I think there's just some real opportunity there for organizations. And the point is that this is not the time to say that's experimental or that's something that one of these days we might do. It's like now's the time to think differently about how you provide services
Yep,
across the board.
I completely agree. And also, it, it is we are past that point, right? Of this being experimental. We are far past that point. I think tomorrow GPT-5 comes out, and that's going to be, just another powerhouse of a model that people should really be looking at AI powered healthcare tech adjacent companies to help supplement some of this and actually take over some of these tasks. I mean, we had talked about earlier, resources, in particular, employees dedicated to just helping with eligibility for those at risk of falling off of Medicaid. Well, why couldn't we use AI and technology to do SMS and IVR campaigns completely automated that are not run by a human being making the calls and sending the texts, but they are humans are leveraging technologies to actually do that work at scale. And that's going to be what changes the game, in my opinion. And so I think that there's a field of opportunity everywhere you look. We just got to start applying it.
I think and I think just in a way, Elios's compliance product is kind of doing that. They're doing 100% audit on all the notes, and then surfacing those that look like they might be problematic to a QI professional. And in a way, I always think about this as it's both that and the direct service product, the ambient listening tools. Both of them are built under the assumption that getting people to do what only they can do and getting the kind of administrivia off their desk. So, instead of having a QI professional look at a sampling of 20% of their notes and hoping that they catch the ones that are problematic, you run them through a compliance tool and it surfaces examples of, this looks like it might be a problem, and then let them use their judgment about whether or not it really is or not. And it's that kind of stuff. I mean, same thing with, like you said, predictive modeling, and there's tools there um, you know, I don't that I do think that this is an opportunity for us to rethink the nature of our business, given these technology changes, given how thinking differently about how we provide care. We had a podcast recently, talked to some folks who were talking about this very thing, and the idea of rethinking how you do stuff, what your workflows are like, um, and this is going to be a challenging time, but these are the times that you need to ask yourself: is do we really need to keep doing that activity that way? Should we be out of that book of business altogether, even though we've done it for 100 years? I mean, those are hard questions, but these are hard times.
I completely agree. I think that, one of the things I love focusing on with my consulting firm are organizations that have perhaps experienced hyper growth over the years, but have been run like a mom and pop for all of those years. And even if their budgets were at first maybe 10 million and now they're 100 million, they still have the same administrative functions or archaic technologies that they're using to manage, their company's finances or their company's front end clinical treatment. And I think, the compliance tool is really of interest, I think, or should be of interest to providers because I don't know when, as a provider group, we're going to start our the provider system, we're going to get serious about tracking, save rates with eligibility and cycle times, those kinds of things as KPIs because they are, like these different data points. What I would want to drive home is that they tell a story, and if you don't know how to use data to tell a meaningful story, then you kind of miss the concept from the start, right from the jump. I feel as if the way in which we get the attention of the lawmakers or of the folks that are making decisions is that we tell really good stories, and we do so with really good data and really good representation of information that isn't not only influential but is also impactful and leaves a mark kind of on the conversation. I think that we have to use technology in order for that to occur at the level that we need it to. And so the time is now. It really kind of comes back to that for me.
Yep. Yeah, me too. I remember, every time had like a huge challenge, when I was in leadership, it always it helped to stop thinking, how can we do more of what we currently do, and take it a step up and say, how do we rethink our business? This is a challenge, but it's also a strategic opportunity to challenge some assumptions that you have about your business model. And one of those is, do we want to invest in technology? But I think more importantly, just the thinking of how people flow through your organization. What services do you provide? I just think that's kind of a global upside of this, that smart leaders will use people like you to come in and say, how do we just rethink this whole book of business? That's that's that if you don't do that, you're missing the opportunity here that this challenge is this crisis is providing.
I completely agree. I call it a forcing event. It's going to force folks who have perhaps been risk averse or maybe really comfortable doing the same thing over and over and trying to scale that into a space where they're, met with a decision point. And I think that if you get to that decision point before someone has to force it on you, then you're going to be in a better spot. And I don't know about you, but when I'm hungry, my needs aren't met, I'm stressed or, I feel like I'm in crisis, I don't make very good decisions all the time, right? I'm looking to, try to stop the burn as fast as I can and try to get back to, stasis as fast as I can. And that is not the strategy. We need to be mindful about that, be forward thinking about the pain points that are coming and not allowing them to creep up on our doorstep. And then, like you had mentioned, that might look like completely changing the book of business that you might have been doing for the last 50 years. And those are hard decisions. And I really want to validate that because I think that that goes hand in hand with trying to critically think about change. You got to acknowledge that it's going to be painful for some at some level, but in the end, is it going to further your mission or sustain your mission? Because the mission can be applied to the decision no matter what that looks like. And so I think it really is going to force, leaders, executives in particular, into those uncomfortable decision points or those spaces where they'll need to pivot. But that's what it's all about. And I think if anything, we know from how legislation works, especially in this country, is that if you're not adapting with it and you're not thinking about it, forward thinking about it strategically, then you're often kind of reacting, and that's not where we want to be right now.
Yep. And I think, and one thing we haven't talked about is that there are resources available to you. One, certainly with your state trade associations. You know, most of the ones I've seen have been really good about staying on top of what the impact is going to be for legislation. So leaning on those, and the other I think that people don't think about often is that their vendors, particularly EHR AI vendors, are can also be consultants. And because, I know in the case of Elias, I know in the case of VHR vendors, they see a lot of different models out there. And they say, you go to your vendor and say, "Hey, how have you seen other people? How are they handling this?" That at least gives you some advice and consult. And I mean, they're still your vendor, you're paying them for a product or service, but they do have a breadth of experience of what they're seeing out there, it's working and what's not working. And you know, if you stay in your own state, you can get into an echo chamber if you're not careful, and you want some creative juices, something. What's working out there? So anyway, good.
I was just gonna say, I think that now is the time that we collaborate with, with folks that we might not traditionally think are resources, like you had mentioned. And I mean, and think about EHRs, right? It's the same code we're billing, but 500 providers are doing it differently. And the vendor is the only one that knows, what those look like, and those customizations, are perhaps more efficient for some and less efficient or less effective for others. So we really need to come together and collaborate on our service delivery models and have those conversations of like, yeah, this is not working for me. And it hasn't for a long time, but you're doing the same thing and it seems like you're doing all right. Like, what's going on? Uh, I think that there's a lot of value to that conversation.
So we're about out of time. Tell me, what would you like to leave our audience with? What what pieces of advice for them about kind of preparing for the road that we're about ready to face?
I've been telling, providers I'm working with, at large, don't panic, but pivot. Kind of been my catchphrase the last month or so, and that's kind of a catch-all for what we've been talking about. I think you need to start the work of strategizing, and I think it starts with educating yourself. I mean, if executives are looking for solutions, then they should probably start by using resources as much as possible to educate themselves about the legalities and the technicalities of this bill. I think we as executives, or as a former executive like myself, spending a lot of time tracking policy, getting to know your state lawmakers, your municipal lawmakers, your county lawmakers, as well as your Congress people, has never been more important. And the thing about legislators that people often forget is that if they don't hear from you, they think everything's okay. And that should just tell you something right there, that you need to be making noise, and you got to do so, as I said earlier, with stories that are impactful and leave a mark. And you have to communicate your needs, but you got to do so in an influential way. And so I would say, for especially leaders in the space, be forward thinking, but also be mindful about how you use your data to tell your story. And then in parallel, educate yourself or get somebody who really is interested in policy to help educate you or your organization. Other things I would leave you with is that it's not all doom and gloom, if you take the time to roadmap your strategy. And that gives you a number of different benefits, including communicating to your organization. I know if I was at an organization and my leadership team didn't say anything about this, I would be very concerned. I would probably be looking for another job because that just tells me that it's not a priority. And so make it known that this is a priority that you're working on with your leadership team. It's a complex problem, but we're not afraid to, take up the challenge and figure out how to exist and sustain and even grow in a really unpredictable environment. And so for, our listeners, I really want to leave, everyone with, again, don't panic, pivot, because there is a silver lining and we got to be able to find it. And we have to continue our work. What we do is so important. We're the experts in our space. And we want to make sure that, we weather the storm and be prepared for the next one.
Great news. Don't panic, pivot. I love that. Our guest today has been Dominic Miller, founder and principal of Sotoro LLC. Thanks, Dominic. This has been a great session and a lot of good information for our listeners. I also want to thank Brooke Andrus, who is our producer, and Harrison Bach, our AV specialist, for helping us produce this issue of or this episode of No Notes. With that, we will call it a day. Thank you again, all.